Okay, hi, this is Elliot Fishman, combing my hair, and I'd like to welcome everybody to Facebook Live. I'm home today. Here's some of my toys in the back and pictures, and hope everybody's doing okay. Um, I think, like many of you, I've never worked from home before, and I do that about one day a week, and then I'm in probably 4 days. But it's kind of one of the challenges. Is it's just it's very funny times. And here I'm getting my message from Lily telling me that we're working because I was having some problems with Facebook. Um, it's interesting, the whole work situation. I think we'll talk about this a different time, perhaps. But one of the things to mention is that the challenge of working from home, whether you have kids, which is a different challenge, or you don't have kids, um, the issue, of course, is how do you maintain that balance? Because it makes it seem like Monday or Wednesday or Friday or Saturday, nothing changes. There's a good article we posted on CTisus this morning from the Harvard Business Review, which makes that point and talks about how you need to create boundaries around working from home so um, that you feel like you're really working, which you are, but it's not like you're working. Like this morning, I got up like 5 o'clock. I was working at 5 o'clock, and now it's 12 o'clock, so that's 7 hours, and I'm gonna keep going on for the rest of the day. I get a few snacks here and there, but besides that, that's the way it goes. So it's kind of interesting in that regard. I'm also, I can't show you, but I'm sitting here with a million computers. So I have two Macs with the Mac I'm speaking on, and I have the my workstations, which I can read and do 3D, and then I have another Mac. So let's get started here. In terms of contrast, we spoke a little bit before on oral contrast and about the importance of positive contrast. I just want to remind people, I don't want to talk about positive contrast today. There's an excellent article by Perry Pickard talking about the importance of oral contrast, particularly in oncology patients. The fact that if you don't use oral contrast, the chance of missing things become very critical, particularly in oncology patients where it's very easy to miss um, implants, for example, or tumors. Let me do one thing. It's hard to look at it. My son will kill me if I have a picture of him twisted sideways. But I think it becomes very important so to give oral contrast. And we went from this era of all positive, waiting 3 hours, to waiting less, to giving water, to the push to give nothing, which is like the worst of all worlds. And we've spoken a little bit about that. I have a new talk on protocols that I'm going to record the next day or so. That'll be out in about a month on CTisus, and I'm going to address that directly. But let's talk a little bit about IV contrast. So I want to go through several different things. So one is in terms of a safety factor. So one of the things we mentioned with CT for doing CTA particularly, but all the stuff that relates to deep learning and relates to all of the work now being done with radiomics is studies need to be done with a really preset protocol. Delivery of IV contrast becomes critical, particularly in terms of injecting at fast rates. Now, people are often afraid to inject at fast rates because they're afraid of contrast extravasation. Well, the question is, so let me ask, does faster injection rates mean a higher extravasation rate? The answer is no. The issue is how well you put the IV and where you put it. So there's an article by Weinbach a number of years ago that makes the point that you have extravasation if you put IVs in the hands, particularly larger bore needles. But in older patients, the veins in the hand look really good and it's very tempting. Those veins are very fragile and they easily rupture. Also, if you're injecting through a small gauge, like a 22 gauge needle, you're going to have a problem. If you're trying to inject at fast rates, the pressure is going to cause extravasation. If you want to go 5 cc's a second, and 18 is ideal from the classic needles, and we're going to come to that in a second, but at least a 20, so you can't have less than a 20. So extravasation rates were higher in older patients using peripheral hand veins and using needles like 22. Now, the challenge, of course, is it's often hard to get a needle in. So first of all, you need to have people who are really good at starting IVs. We do. Then there was a change a couple of years ago by Beck and Dickinson, and we have no conflict of interest, though Pam Johnson and I Gail Christensen wrote some articles a couple of years back when they were testing the catheter. There's something called an Nexiva catheter. It's a fenestrated catheter, so instead of a hole at the bottom, there's a hole at the bottom and the number of 4 or 5 side holes. And through those side holes, it's very, very easy, very easy to inject high rates. And yet the needle doesn't need to be a 14 gauge or 18 gauge. So I'm reading the chart on a Nexiva needle. A 20 gauge needle, you can inject 10 cc's a second. So really, you would never need an 18 gauge needle. Now you have to learn how to use the B&D catheters. It's a little bit different than some of the others, but it's an hour of training, and they give you these dummies to test it on. That's not people, but a real phantom type dummy where you can do the testing. And then you could inject. So it's a wonderful needle. It doesn't harm the patient's vein because it's kind of like the exhaust from a rocket. It goes through multiple holes, so you don't have the pressure through the bottom and it explodes. Multiple side holes, and so that works out very nicely. So that's very important. The next thing is non-ionic versus isosmoler. The issue with isosmoler really comes down to cost. I think if it wasn't cost, everyone would do 100% isosmoler. Even the minor reactions of feeling warm or funny taste disappear with isosmoler. We use isosmoler for all of our pediatric patients. Many people use it for cath or cardiac. We use it for a lot of our patients, particularly patients who are at higher risk. And there's been a number of different articles about that. Now, one of the other things about contrast, and it's always driven me crazy, and I've spoken about this for the last 30 years, about how people with a creatinine of 1.3 or 1.4, people were always worried about giving IV contrast. And there's been a number of different articles published recently that shows, and there was actually an NPR about 6 months ago that showed, and I'm reading the quote, are the risks of drugs that enhance imaging tests overblown? And that exactly was the problem. A lot of the stuff that people believed was what my grandmother would say was Baba Misa. Stuff from the old, you gotta be from the old country to understand that. But basically it meant it was urban legend. Now remember, in the old days, you were giving 150 to 200 cc's of ionic contrast after the patient was dehydrated, being NPO after midnight. No wonder the patients threw up. No wonder the patients got sick. No wonder the patients had problems. But also, we've tested, and then they also, the way you tested creatinine going up was 3 days post-injection. If it went up more than 25%, it was a contrast-induced renal issue. We now know that creatinine levels are not flat lines. They're more like the stock market this year, up and down, up and down. And a couple people wrote articles where they would have 2 people in a room. One got contrast, one didn't, and the patient who didn't get the contrast, their creatinine went up more than the patient who did. So Newhouse wrote a number of articles looking back to 2008. The creatinine level in patients who are not receiving contrast as often as it does in published series of patients who are receiving contrast. So creatinine levels, just measuring them on patients is not a good measure because creatinine will vary day to day. And that's a very, very important point. There was an article from Hopkins by Hinson in the ER setting where they looked at something like 5 years of data and no one ever got contrast-induced nephropathy. So they made the point, of course, that perhaps they weren't giving enough patients contrast, which I agreed on. Now, in terms of renal function, do you need to get creatinine levels? And this is something that is always open to debate. Some people do not, some people do. So what are we doing? This is sort of a compromise by us. And this is, so if a patient's on dialysis and getting dialysis, you don't need to worry about their creatinine level because obviously it's going to be under 30, but the patient's being dialyzed, no issue. If a patient has any of the following risk factors and there's no GFR on record within 90 days, a serum creatinine will be performed. Now remember, we can do serum creatinine GFRs or we can do point of care. The point of care is very good, it's cheaper and much more convenient, but the people from pathology feel point of care on certain patients isn't that accurate. So if you've had a renal transplant, a total nephrectomy, documentation of any type of chronic kidney disease in the health records, or a GFR within 90 days that's under 30, then we're going to want a serum creatinine. If you have any of the risk factors, including over age 60, diabetes, and a single kidney, then we'll do a point of care. Again, that works out okay. Now, one of the things to recognize is people used to say below 60, you don't want to give contrast, then below 50, what about 45? Now your GFR is above 30, we give contrast. 90 to 100 cc's, you can cut it back a little bit depending on the application. But there is no issue. If the patient's creatinine is less than 30, then, or GFR is less than 30, if the study is necessary, we will do it. Okay. Now another thing, a practical thing, do you have a warmer? If I asked that question 20 years ago, everyone would say yes. Now 10% of people say yes. In the old days, the farm companies, the Amershams and the GEs, and will give you a free warmer, and you put stuff in the warmer. Now you got to buy the warmer, so nobody has a warmer. Well, the warmer is very valuable. It costs a few bucks, and if you warm contrast, what happens is you don't have much of the secondary side effects. Patients don't feel nauseous, they don't feel warm. It works out very much better. And also there was an article from Duke a number of years ago that showed that if you did not warm contrast and were injecting at 5 cc's or better, you would triple the extravasation rate. So from a safety factor, you need to warm the contrast. Now, why don't people warm contrast? Again, it's buying that stupid container. And the other problem is when we get the hospitals, the Joint Commission's reviews, you have to monitor your warmer. So for example, they want you to put a temperature down every day, and none of the warmers really is state of the art where it automatically goes to your iPhone or to a secondary device. That would be a great business. I'm planning on that sooner or later. Okay, so get a warmer. I'm telling you, get a warmer. There's no warmers on eBay, by the way. Now, the other question becomes, what if patients had contrast reactions? How do you prep them? I like a 24-hour prep, and the reason for that is our people in allergy at Hopkins told me years ago that if you're giving steroids, you need to have 24 hours for it to work. Now, the ACR has a 13-hour prep. Okay, we can use that. Some people have talked about a 5-hour prep, but it's not quite as good. So I like 24. But if a patient has an emergency need for a CT scan, we'll give 100 milligrams of prednisone IV and then do the scan. So everything's a risk reward. You have to be aware. And if someone needs a scan, we can do a 5-hour prep. We can do an 11-hour prep. But if ideally, particularly outpatient setting, you're scheduling the patient, here it is. Just do it before. Okay, really good. Now, I also should mention about delayed contrast reactions. Now, every once in a while, people would call us up and say they had a reaction. They have hives. It'd be like 3 days later. You say, listen, you must have eaten something. There's no chance. Well, the reality is patients can get delayed reactions, and that's defined as reaction 1 hour to 1 week after contrast. 1 week, okay? The majority is between 3 hours and 2 days, but it can be a week later. Often the rashes are extensive, and patients will need to be treated. So they need to go see the doctor or go to the ER. They can have very extensive rashes that need to be treated with steroids. Now, these patients are problematic because the next time they get contrast, very much the same thing. There's a 25% recurrence rate. It's typically a T-cell mediated hypersensitivity, H1 and antihistamine prophylaxis. Its use is not quite clear. So one of the things to do is change contrast. So if you were using Omnipaque, then use Visapaque. If you had Visapaque, then use Omnipaque, okay? That's what you really want to do. And again, that works out very, very, very nicely. So again, it's very important to really understand that. Now, it's a good time to ask questions. Hey, there's Meg Fines. She says hello. She's not in Hawaii. I think she's in New Jersey. And Alberto from Oklahoma, and Whitney from Battery Park in New York at lunch time at the ranch there. And Edgar of South Carolina. And Dogard has a question. If the GFR is low but creatinine level is good, that's pretty unusual. I mean, truthfully, often you'll see a creatinine level will be, particularly in older women, will be a bit high, and the GFR will be okay. Typically, people will go with the GFR. That really is the standard of care now, to go with GFR. Now, if people have more questions, it's a good time to ask those questions. Other things that relate to contrast, injection volumes, I think most of the time 100 to 110 cc's is all you need. Some studies you can do substantially less. I don't like dual injection with then saline on one side and a push. I think the cost is more. You need more tubing. The chance of getting air in the lines increases. The complexity increases. And the cost of contrast, particularly non-ionic, is so low now that the cost of tubing is much higher. It's interesting, most of you don't look at cost, but if you look at the cost on your Medrad injector, and we love Medrad, we've had it forever, they work great. But Medrad made a lot of money because they made tubing. Remember, you want to be in replacement parts. That's like intuitive surgery with laparoscopic surgery. It's a $3 million machine that they can give you for free because every surgery costs thousands of dollars in parts. So the tubing and the connecting, which takes time and everything else, it's very, very important to, that's very expensive. And again, anything we have more and more connections creates a problem with air emboli. And I've seen a number of cases with air in the lines and air in the injection. It's always going to be outside studies, but you see air in the heart, and you can have an air embolism. So you need to be very, very careful. To me, the more connections there are, the more concerned I am. And that really is somewhat worrisome to me. Now, what else? Let's see. Anybody else have any questions? I don't see any other questions. So what other things can I at least mention? In terms of contrast, some things which I will talk about in the talk really relate to things like AI. One of the things with AI is fast injections, the timing being the same from time A to time B, and between patients. This becomes very important because if you're going to use AI for determining the tumor type, if you're going to use AI for determining how to manage the patient, the contrast and the AV shunting within the tumor becomes critical. If you don't inject fast enough, you can't really judge that. And so a lot of the consistency that we need is going to be there. I see John Biachino's home today, so he's up in Timonium, listening in. Hey, John. So I think that becomes very, very important as well. So I will go back to one more thing with contrast, and that's just to mention about oral contrast. I think we've mentioned before that we've always used, we started with HiPEG, then we used the Omnipeg, and we used to mix it in a container. Now we use the individual bottles. I will say that the individual bottles, which are in the 6 or 9 milligram types, are ideal for what we do. I like the 6. You can see the picture, which I can't show you because you're not looking at it. It's 9 and 12 milligrams of iodine per ml. We like the 9 milligrams. It's a bottle that kind of looks like a vitamin water bottle, typical bottle. It's pre-mixed, right? So there's no mixing. And in this COVID era, when you want to push patients through the scanner and then have time to clean, where you want patients to feel comfortable that everything is sterile, if you give them the bottle and you can just open the twist, or they can open it themselves, they know it's clean, they know no one touched it. If you're making a gallon of contrast, then you're pouring it in cups, the chance of things happening really becomes problematic in that regard. And you create a lot more trash, which is stuff we don't want to do these days. So the oral bottles, the single-use bottles, are really good in that scenario. Obviously, they're also good in the ER setting because you can have them sitting around or in the Pyxis, and they can give them to the patients quickly, so you're not wasting a whole lot of time when you're doing things, and you can give the patients oral and get the throughput you need without the ER docs complaining. So that's basically a focus on IV contrast with a little bit on oral contrast. If you have any other questions, you can think of it. Prednisone start reacting with 30, here is a question. Prednisone start reacting with 30 minutes. A patient has allergic reaction. Okay. I'm not sure what the question is. I think in terms of prednisone, if you just give it when someone's having a reaction, that's not going to help. Prednisone needs to be before. Again, the argument, we do 24 hours, 40, 40, 40, 24, 12, 2. Some people do 13, 5, 1. People do 5, 3, 1. For a patient with emergency, do 60 minutes, 100 IV push, Cymedrol, or even just right before you do the study. But I think you really prefer not to give the prednisone after if someone has a reaction. You really need to do it before. I think you really need to think about it with that. Let me see. All ER patients are scanned with PE protal shortness of breath. chest pain, even coronavirus. Do you justify this? I won't get into justification, but you can't scan everybody with a P protocol, right? You need to look at why we're doing the study. It may be just a question pneumonia. You may need to do a non-contrast study, like rule out COVID. That's a non-contrast study. Also, if you're doing a PE study, the timing would be different than if you were doing an aortic dissection study, or a study to rule out adenopathy or tumor. So, it's not a one protocol fits all for all patients in the ER setting. There's Liliana saying hi from California. Hi, Liliana. Liliana showed me some great pictures from California. I think I was going to post them from the ocean, which is the Pacific Ocean. My question now from Ronnie. My question would be, what is a lymphoma? What is it that makes it appear or clear on a CT image? So, obviously, not a physician, and I don't want to answer patients' questions. Lymphoma is adenopathy, but you should ask your physician if they have questions, or if you go to radiologyinfo.org, it has a lot about lymphoma on there and goes through description, and it's written for patients. So I hope that helps. So with that, my time is up. I thank everybody for coming, and we'll see you next time. Have a great day.